Mr. Chairman, thank you for the presentation. Colleagues, give me an honor to be here to address you for the work that we have been doing in the Arabian Gulf University College of Medicine. This is actually a university in Bahrain funded by the GCC country, the Arabian Gulf state, and we have a College of Medicine, and in College of Medicine there are a lot of departments, and my department, which is microbiology, has been recently working on antimicrobial peptide. We found that this subject is very interesting and we would like to take it further. So sepsis is a multifactorial disease which involves a lot of syndromes, and but what worries us is the increasing incidence and prevalence of sepsis in our part of the world and worldwide. For instance, 10 to 30% of intensive care patients in the United States have severe sepsis. The mortality rate is very high. If we talk about our own area, we have about 20 to 40% mortality rate in ICU from sepsis. Sepsis is, with the increased number of antibiotic use and without control and stewardships, you will see a high level of resistance. Our resistance rate is very high, and we have multiple drug-resistant organism, which is difficult to treat. Of course, as I said, sepsis is a complicated syndrome, and SIRS is the condition where patient goes into hyper or hypothermia, heart rate will be high, and the count, and goes into sepsis only when there is an infectious process. And there is sepsis first characterized by a first hit and a second hit. Usually the acute phase is the first hit, which a lot of the immunoregulatory mechanism and immunological cell works. And there will be hyper-inflammatory process, and then there will be immunosuppression. Here, when we got interested to know if there is any role of antimicrobial peptide, because a lot of work has been done on finding out what is the effect of antimicrobial peptide in vitro, but none is done in vivo. And this is what prompted us to go and find out how is beta defensin, for instance, as an example, beta defensin 2 is behaving in these patients. So just to give you a brief idea, maybe this morning you had a brief idea about beta defensin or antimicrobial peptide in general, but they are very promising candidates for to kill organisms, because they kill organisms, they are positively charged. Usually microorganisms are negatively charged, and they can be attached to them. They're only not involved in killing the bacteria, but also involved in immunomodulation and immunosuppression and immunoactivation. And that's actually what most people are trying to do now, is to knock out because it is a double-edged sword. If you talk about beta defensin, for instance, it can kill the organism, but at the same time, it can also modulate and activate the immunotherapy with something you don't want in sepsis. So in vitro, there are a lot of work has been done on this area. But for us, we wanted to know how is beta defensin, for instance, is behaving here. So this is just a slide showing how those peptide can actually do immunomodulation by activating lymphocyte, monocyte. They can enhance bacteria clearing and control inflammation and sepsis. They can also induce the production of IL-8 and IL-12 and IL-10 for this matter. But at the same time, they can kill directly the microorganism by actually forming pore formation, or they can do a carpet model in which they can rearrange the membrane. But definitely, they can easily make pore formation. The beta defensin, which is the peptide that we are working with, it has 18 to 45 amino acids. It is characterized by multiple cysteine, and it has a broad spectrum activity, bacteria, fungal, viruses. They can also kill viruses by binding to the co-receptors. And there are recent study showing that they have an effect on HIV by binding to the co-receptor. So as I said, also they are pro-inflammatory and chemotactic, and they can activate immature dendritic cell and a neutrophil. There are about now 6 beta defensin, but I think there will emerge, people will also do more to discover more. But our beta defensin, this is their structure, usually a single motif with 4 disulfide bond. We came to be interested in this molecule because we think that this molecule can actually tell us whether the patient will go into a severe sepsis or not. We wanted to use it as a biomarker. And for the therapeutical agent, I think a lot of work has to be done to do this. But as I said, they are found in everywhere. They can be a potential treatment. They are being used to treat. Also, they have an effect for wound healing, and this is one of the process that I didn't go through. And they are being now used to treat post chemotherapy patient with wound infection, and they are actually very, very helpful. So in our study, we actually took about 60 patients. 30 patients were having sepsis. 10 patients have critical ill, but they are not sepsis, and 20 control. They were recruited directly from the hospital in our ICU unit, and they were mainly the surgical ICU unit. A critical ill patient will taking either from the same unit, but with no septic activity or sepsis activity, and all being diagnosed according to the American College of Chest and Pathology Society, which definition, as I showed earlier. We actually designed the primer using this the gene bank using the NCBT primer blast, and we have used also the beta defense, the beta actin as a internal reference and internal control for quantification. These are the best bets of the primer that we used. And we didn't use the standard care, we used delta CT quantitative method by calculating the delta CT for the control and the delta CT for the case. Actually, we use real-time PCR, but I will show you how we also optimize the actual PCR to get a product. These are our optimization condition in which we use the primers, and we use different annealing temperature, and we found that the 3M and magnesium chloride with 60 annealing temperature is the perfect temperature to use. And also we checked our the cDNA integrity and found to be perfect. This is just a manual also run for our patient, and you can see that the beta defensin is clearly amplified in those patients and in those without sepsis. But I will show you the difference now. So when we use quantitative method, we actually know how much is being there at the beginning of each cycle, and usually at the beginning when we see at the cycle where we see a level of the blood above the threshold, and you can see that we actually done all this to quantify our CT. You have to have a CT, the average CT with the average control to be very equal, and you can see it here that the average CT of the BD2 is equal, roughly equal to the average CT of the control, which is the beta actin, a housekeeping gene that we use here. You can see here the blotting curve and the melting curve of our experiment, and you can see the threshold at the beginning of the cycles where we have a product. Similarly, this is for the beta actin 2 as our control. And this is basically what we have documented, that those patients with sepsis, there are significant increase of the amount of beta defensin 2 on patients with sepsis compared with non-septic patients. And we believe that these patients are being using, or the beta defensin itself is upregulated in those patients. And this is the first documentation of that we've done in this in our population, at least. Other people have done this, and they found a similar result. And this is actually showing a p-value less than 0.04 compared to the critically ill non-septic patient. But this is a more interesting result. This is when the patient gone into shock. There is a deregulation of beta defensin 2. And here, where our experiment became very interesting, because those people without shock show a normal level of beta defensin. But when they gone into shock, and this is what I was referring to at the beginning of my talk, when I said a second hit. A second hit, usually beta defensin is dysregulated. And This is what actually might be happening, that the patient will first shoot beta defensin, try to manipulate, kill organism, modulate the infection, but can't, then the patient will go into shock. We believe also that there is a genetic differences. There are studies showing individuals who are susceptible to sepsis and consequences. And this actually might be related to beta defensin, because if the patient are able to mount an immune response with beta defensin and stay at the top, might be protected from going to septic shock. And those people who can't mount a continuous response of beta defensin 2 might be susceptible to go into septic shock. Dysregulation, the title of my talk, the dysregulation of beta defensin 2 is quite evident in this slide. So in summary, what I wanted to say, that beta defensin 2 expressed in peripheral blood of Bahraini patient and critically ill patient. There is a significant increase in sepsis compared with critically ill, suggested that beta defensin 2 could be used as a mechanism induced during inflammation and can be used as a biological marker. Importantly, that there is a BD2 significant lower in sepsis with septic shock to sepsis patient without septic possible due to the impairment of the immune response and the susceptibility to go into shock. And this is what my talk is all about. And thank you very much.
Thank you for this wonderful contribution in defense in molecules, which are really important in our resistance to
Microorganism.
Are there any questions from the audience? Yes.
I'm quite interested in the timing of the lowering of HBD2.
Yes.
Can it be used as a predictor of someone going into shock, or does it correlate exactly with the time they go into shock?
Well, actually, the patient that we collected the blood from has already went into shock. But this is what I'm thinking of. Biomarker that we monitor the patient daily in the ICU and see their level of, once the patient, see the problem is the treatment policies in the ICUs are varying according to the consultant who's working there. One consultant will say, start antibiotic immediately. Patient will wait. Other consultant will say, no, I will start later. Patient will develop candidemia and die. By that time, I think the good idea is to monitor beta defensin 2 once the patient going into ICU, post-trauma, going after post-operative, patient with chemotherapy, they should be monitored by the beta defensin 2.
So you could do a future study where you do like a time course following.
This is actually the next study that we are doing. Actually, you prompted us to do it. Because this actually I want to contribute to thank my colleagues and my student who work on this. This is actually part of a MSc thesis in our college. We run, I want to do some, we call the eye in Arabic. Advertising for our course.
Yeah.
Can I do it?
Yeah, we can do it.
We have a master program in our college. We do a master program, and this thesis is actually part of their defense. Thank you very much.
Are there further questions? Yeah, you have another one?
If I'm allowed. I wanted to know why you've chosen RT-PCR to measure RNA levels, which is a surrogate for the amount of protein, rather than ELISA, which would measure the direct amount of protein.
Exactly. We actually wanted to do RT-PCR to know whether the gene is expressed. Therefore, we actually know that the protein should be there. But we can actually run a quantitative protein analysis on that parallel to this experiment. But this is a very pilot sort of study that we wanted to do more, more on ELISA and do the amount of protein itself.
Are there commercial antibodies available against HBD2?
I think there is, yeah. There is. So you can just do. What are you thinking of?
Well, you could measure the actual levels in the blood by ELISA. I was just wondering why you chose to measure a sort of.
We actually do an RT-PCR for expression analysis and messenger RNA expression, which we believe that is very accurate with regard to the level of protein. Because level of protein usually is, I don't underestimate the level of protein, but once you know whether they are expressed or not, then the protein should be there. There are, we've done before some studies when we, basically it's more expensive to do ELISA with the analysis of this one. So you have to choose either to do a protein or this one. Because these students are paying themselves, so that's why.
They don't have to buy the machine then?
They
don't have to buy the machine?
The machine is already there and bought by the institute. The students buy their own stuff. But your point is well taken. We actually are going to do this with protein analysis.
And that might be a diagnostic kit to make some shifts in innate to specific information processes.
They're too obvious, aren't they?
That's too obvious, yes, indeed. Okay, thank you for your.
Thank you very much.
Are there more questions? No? Then, Professor, I also present you the certificate of recognition.
Can everybody take a photo because I came alone